Got some great photos here of a lot of our students, some of our patients. There's a photo of dry needling. That's me working with some cricket guys here in the US. The picture at the bottom right, on the far bottom right is me, obviously. And then on the left of that photo is my business partner, Arva Morbiwala. She is from Mumbai, and we have this business together, this physical therapy business together. And the gentleman sitting next to Arva is actually one of the Dallas Mavericks professional basketball players. He's an NBA player, and we were doing treatment and stuff like that at a basketball camp that he was having around here. I like to include this picture. It's just kind of this happens to be a picture of the US at nighttime. My favorite is the one of India at nighttime, but in this lecture, it's the one of the US. And so I like to show this picture to start thinking about, the Earth, the whole planet, and you start thinking about, how is physical therapy practiced around the globe? And there's a lot of differences in how it's practiced around the globe. But when we look into the future, for people on this planet that need help with musculoskeletal pain, right? Aches, pains, nerve pain. I can't turn my neck. I can't straighten my back. I've had a surgery and I need help recovering, or I've recovered from my surgery, but I'm still having pain and problems. I'm an athlete with a sports injury. I've had a headache. I've got a concussion, migraine, temporomandibular joint disorder, vestibular. The scope of physiotherapy is massive. The amount of people that we get to help is massive. And I'm from Zimbabwe. I can say this. I've traveled the world. I can say this. How physiotherapy is practiced in different places, it varies a lot. One of the things that I like about some of the countries that are really big in physiotherapy, where physiotherapy has evolved, I would say in America, Australia, Canada, and I think actually India is progressing at a really fast rate. I mean, the education is obviously it's marvelous. I think evidence-based practice, I think that's growing in India. I also think that manual therapy is growing in India. It's definitely a trend, like it's definitely a trend right now. And maybe it is in many parts of the world. And I have some comments about that in just a minute. I love this slide. The body's a map if you know how to read it, so learn how to read it. The body really is a map. When people have, pain in the body, weakness in the body, there's all kinds of things that we as physiotherapists can see in the way that patient moves and the way that patient walks. And when we put our hands on their body, there's so much information that we can gather if you know how to read the map. I have patients all day, every day, and I'll just touch their neck. And they're like, how did you know it hurts right there? It's my job to know. The body's like a map. How did you know it hurts right here? Like that spot is so tender. And I'm like, yeah, I know. And I'll poke, you know what I mean? And stuff like that. And so that intuition that you get between your head and your hands, like that connection that you get between your head and your hands, the body really is a map. And the more you practice reading the map and understanding the map, the better physical therapist you'll be, especially the better manual therapist you'll be. You guys make sure that you connect with us. So on YouTube, we have so many like free lectures and cool things that we've done, just like this one. On Facebook, Gem Physio, on Instagram at Gem Physio. And I'm hoping you guys will tune into some of our free lectures in which we're going to really dive into a lot. We're going to learn a lot. I'm not going to withhold anything. I'm not going to gaslight anyone. We're going to show like manipulations, manual therapy, muscle energy techniques. We're going to show so much. And hopefully you guys will enjoy it. And maybe it'll make you guys hungry to tune in for more lectures. Maybe it'll even make you guys hungry enough that eventually you decide you want to attend a live lecture of ours sometime. In-person lecture and lab of ours sometime. Or maybe you want to join our online cohort where we systematically go through the whole body and talk about the foundational anatomy and physiology, and then the biomechanics, and then how is everything connected neurologically, and how do we diagnose different problems based on literature, research, and your hands. And then how do we go about treating those things with live videos for dry needling, for manual therapy, for manipulations, for METs, for all of it, including like exercises and stuff like that. And all of it's coming from the highest level, right, of physiotherapy. And I'll tell you a little bit more about what that means in a sec. So today's free 1.5 hour lecture that we're doing is on manual therapy for pain relief. And these are going to be my favorite techniques, tried and tested over almost 15 years of being a physiotherapist, that I have picked up from doctorate of physical therapy, that I've picked up from my specialization, that I've picked up from the fellowship program that I did, which was 4 years and 440 hours of being mentored and working with experts. It comes from my time working with Dr. Tajinder Singh, who is the other physio here at GEM, and ones that I've picked up along the way, from my travels or from the many different clinics that I've worked at and stuff like that. So it's a really excellent, solid variety. If you guys see techniques today that you are not using, I promise you're missing out, because these techniques, one of the things that I'm really, really, really good at as a physiotherapist is getting rid of pain quickly. And I've got one of my PTs here today, Ida, and you guys will get to meet him in a little bit, talk to him in a little bit and stuff like that. But what he can tell you and what he's done for himself is because he's a hungry student, just like you guys are, right? Like it's Sunday night, 6:30 in India. It's 8 a.m. here in the USA. I have no idea what time it is in Nigeria, but I'm so glad that you guys are here. And stuff like that. So, but you guys are hungry. You guys are here because you're hungry, because you're interested. And that's so characteristic of our students, of our participants, is that you guys are hungry and interested. And, my guy Aiden over here, in just a few months of working here, because of his hunger and his passion and his commitment, I mean, this guy is a pretty new grad, but he's going to be in like the top 5% of therapists as far as like manual therapy skills goes and stuff like that. He can do like everything. So I think if you're smart and you're hungry, it doesn't have to take a long time or a lot of effort. I think my road to get here was very long, but I don't think the road to become an excellent physical therapist is really that long per se, but I do think it takes dedication. I do think that it takes dedication and effort. So what is manual therapy? We're not going to use an official definition from like an academy or a body of oversight or something like that. We're just going to use basic stuff, right? Manual therapy, it's what we do with our hands, right? It's joint manipulation, joint mobilization, muscle energy techniques, myofascial soft tissue techniques. And I've included dry needling in here. Some people include it in manual therapy, some people don't. I don't care. We'll go ahead and include it for our intents and purposes today. Why manual therapy? Why should you be using manual therapy? And why should you not just be using it, but why should you be an expert at manual therapy? These are a couple of reasons I've put on here for today. I think one is the patient experience. Patients that are in pain, when you lay hands on them, there's this connection, right? You instill confidence into your patient feels heard, they feel like you're automatically, I think it just builds your rapport with the patient, right? That's one thing. Just laying hands on patients, that's one thing. Psychologically, that patient is in a much better place just from that. It helps. The next point is that so the PT can better understand the diagnosis. One example of this would be the patient comes to you for plantar fasciitis. Maybe the doctor sent them to you for plantar fasciitis, or maybe they just came in off the street wanting to be treated for plantar fasciitis, right? A manual therapist would be able to, in about 5 seconds, determine whether or not it's actually plantar fasciitis, because pain in the bottom of the foot is not always plantar fasciitis, right? You can have heel pain that comes from Achilles problems. You can have heel pain that comes from low back and sciatic nerve problems. You can have abductor hallucis, can be irritated or inflamed. You can have posterior tib tendonitis. You can have true plantar fasciitis. So there's so many different things that can be going on. And so one of the reasons for manual therapy, we get hands-on as part of our assessment and part of our treatment. And if you run a differential diagnosis, you won't waste your time or the patient's time. Okay. And so this is about part of manual therapy. And I think one of like the pillars of GEM, Global Initiative for Expert Manual Therapists, is getting to the root cause of the problem. If you don't have that, you don't have anything and you're just guessing, right? And I think that many therapists struggle with that. Many therapists just take the doctor's diagnosis or what the patient thinks the diagnosis is or what the X-ray or the MRI says the diagnosis is. None of those are a diagnosis. You can have an L4 disc herniation, but that's not what's causing pain in the patient. It could be their SI joint. It could be a facet dysfunction. It could be something else. And so, the diagnosis is a multifactorial thing that we're not going to get into a lot today, but basically manual therapy, when you get hands-on, when you start assessing and treating your patient, it gives you a much better understanding of the diagnosis. And it helps us with our differential diagnosis to arrive at the right diagnosis for treatment. Another bullet point on this slide is so that the PT can better understand the response to pain in the patient's body. And this is going to open up a soapbox that I have, right? Or something that I say this to patients like all day, every day. Okay. Patients say, my upper trapezius hurts. Okay. Maybe it's your upper trapezius, maybe it's not. Let's have a look and see. And this goes back to kind of the whole differential diagnosis thing, but what I always tell patients is, you know what? Like sometimes in the human body, when patients come here with pain, sometimes a muscle is the primary problem, right? Sometimes they have really pulled a muscle or overworked a muscle. That can happen. But when patients come to me and they tell me my calf is cramping, is it their calf? Is it their sciatic nerve? Patients tell me my tennis elbow is hurting. Is it the tendon and the muscle, or is it the radial nerve that runs in there? Patients tell me, oh, my back muscles are on spasm. Okay, your back muscles are on spasm, but it may not be their fault. They're probably spasming in response to something. Patients come in with IT band and piriformis syndrome. I don't think that IT band and piriformis, I don't think that's the problem. That's usually the secondary or tertiary or quaternary manifestation of a problem. And so let's directly talk about this bullet point now. So what's the response to pain in a person's body? Take any region of the body, right? Pick a diagnosis. And in that region of the body, what's going to happen is in the presence of pain, not sometimes, every damn time, some muscles in that area in response to pain, say it's a disc or a facet or whatever, in response to pain, some muscles are going to become hypertonic. They're going to be on spasm. They're going to be guarding, protecting, whatever. So you'll always get muscles that become tense and hypertonic in the presence of pain. And you will always get other muscles, predictable muscles, that are going to become inhibited in the presence of pain. So in the neck, suboccipitals, upper traps, levator scap, and sometimes the paraspinals of the neck become hypertonic. Scalenes, definitely the scalenes too. The muscles that become weak or inhibited is a better word, because the muscles didn't magically become weak, but in the presence of pain, they became inhibited, right? The deep neck flexors, right? In the shoulder, it's the rotator cuff becomes weak and inhibited, and then sometimes some of the scapular muscles like serratus, mid traps, lower traps, upper traps. Which muscles become hypertonic in the shoulders? Pec minor, right? We're always stretching those muscles out. Deltoids often do, and then sometimes the teres muscles. You know, it kind of varies and stuff like that depending on the diagnosis. But yeah, what about in the low back and hip area? So in the low back, we already know the paraspinals are going to tense up, maybe piriformis, sometimes IT band, sometimes the hip flexor. Which muscles become weak and inhibited? The abs, the multifidus, glute max, glute medius, and the deep hip external rotators, right? And so when we lay hands on our patients, we can feel those hypertonic muscles. And that helps us to understand better what's going on. So why manual therapy? Manual therapy has excellent evidence, very powerful effects, biomechanical and neurological and psychological. You could argue. I don't play up the psychological part very much, but it's true. And when you combine it with when you combine manual therapy with exercises and stretches, this is what all the research says we should be doing. There's a website, the orthopedic sections of the American Physical Therapy Association. They have a website, and on this website, and we can get you guys the link if you guys are interested, but on this website, they have clinical practice guidelines. If you get this diagnosis, this is level A evidence, this is level B evidence, this is level C evidence, this is level D evidence. Level D and level E you shouldn't do. And sometimes ultrasound should not be done. And sometimes E-stim doesn't have that much evidence. Sometimes kinesiotape doesn't have evidence. Sometimes dry needling doesn't have evidence. And sometimes they do. And so we want to know in the conditions that we're going to treat, what is level A and level B evidence? And every damn time, manual therapy combined with exercise is the best thing that you can do for your patients that have musculoskeletal pain. So it's not just a skill set that you add on and flash around. This is foundational. And I will tell you that if manual therapy and exercise is what everyone should be doing, and if that is the international global standard, that even in the United States, probably 80 to 90% of physical therapists fall short because they have not mastered that skill set. And you guys are going to master it. You guys need to. You guys will. There are resources. You've got patients. You've got peers, right? You've got, yeah. So a trend that I see in the world today, and I've traveled to India a lot. So definitely in India, this is something that's going on. And I talk to my students and I talk to Dhrumi, you know, some of our faculty and staff over at GEM, have conversations with TJ about this and stuff like that. But the question is, what happens if you give a monkey a violin? Essentially, that's what's happened in a lot of countries. We have taken an instrument that can produce beautiful music, right? Like a violin is the sound is so beautiful. Violin, a cello, whatever. The sound is so beautiful. But what happens if you give that instrument to a monkey, right? Someone who they don't know how to use it well. A monkey's going to carry it around. They might even like try to play it a little bit. Maybe they'll make some noise on it, but is it being used effectively? No. And this is what's happened with manual therapy internationally is there's this big wave of, oh, like I became a chiropractor because I attended a 1-week course, or I became an osteopath because I got a certificate that says I am, or I became a manual therapist because of whatever the reason may be. And so what's happening is that so many people are claiming to be manual therapists because of this certificate or this weekend course. And I'm just going to tell you that unfortunately, it's not that easy. It's not that easy. And so we have a lot of amateur manual therapists, chiropractors, and osteopaths. And this is a call for the real manual therapists to please stand up. Who is a real manual therapist? Well, first of all, you have an education, a background in physio. I don't care if it's BPT, bachelor's. I don't care if it's MPT, a master's. I don't care if it's DPT, doctorate. As far as I'm concerned, none of those, not even the doctorate of physical therapy, provides you with a halfway decent skill set in manual therapy. This is something you must pick up through experience and practice and effort and education. So in 2025, cross-trained physiotherapists, which means that you can do regular physio, you can do manual therapy, and I'm going to say that there are instances when you need to be able to do dry needling. Not that many instances, mind you, but there are certain things that dry needling is very powerful for, and you should be able to do it. I'm going to say headaches, migraines, and TMJ. Headaches, migraines, and temporomandibular joint disorder. Dry needling is a no-brainer. Okay, you need to be able to do that because it makes a huge difference. It can be used for other things too, but as far as the evidence goes, dry needling is incredible for those things, okay? So in 2025, a cross-trained physiotherapist, that's you guys, or that could be you guys, right? A cross-trained physio is the person that should be the first choice for musculoskeletal pain. In America, people go to acupuncture, people go to chiropractor, people go here, people go there, people go for a medical massage. I don't know, I'm not going to use a bad word. I don't know what the heck that is. I don't know what a medical massage is. People go to a Rosti, people do this, people go all places. But really, when you break things down, when you look at what should be done for these people's musculoskeletal pain, they need someone who can do manual therapy, physiotherapy, which is stretches, exercises, and we also talk about, you know, the long-term fix and how to have their posture better and how to get strong and stuff like that. So physiotherapists, really, we should be able to do everything. If you go to a chiropractor and all you do is get stuff popped, that's just a short-term fix, and sometimes it's not appropriate. If all you do is you go to acupuncture, okay, but that's like 3,000-year-old Chinese medicine, and it's not a holistic approach. There's so much more we can do than that for your aches and pains. And then if you go to a physio where you're getting electrical stimulation and ultrasound and heat and some massage and some exercises, that's just not up to scratch. Like, I'm sorry, but that's physiotherapy from like the 1980s, and time has passed. It's been 45 years since 1980, right? And so the physiotherapy must evolve and must change. And right now, what the research is here, and most physios are here. So it's up to us. And this is a decision I made when I was a new physical therapist, right? I said, compared to that physio over there who knows how to pop and crack and make people better and just see things differently, I said, she's here, I'm here. I want to be here. And so I went through years of submitting myself to working under someone to learn, to read, to study, to do a fellowship program. And so effectively, this gap that needs to be bridged, you can bridge it however you want to. Reading, practicing, working with good physical therapists, taking courses. What GEM is the bridge. GEM is the bridge from wherever you are to expert manual therapist by global standards. And so that's what we are. We're almost done with some of this background stuff, and then we're going to jump in and do some lab and demo stuff, which will be fun. So I challenge you to make it your personal goal as a physical therapist to become an expert manual therapist by global standards. All right, by global standards. What do I mean by that? Okay, so here in the US, a basic physical therapy degree is a doctorate. And doctors of physical therapists suck at manual therapy. I can say that because I have students. I've had so many students. I've had like 20 or 30 students that I've come and spent time with me when they're finishing up their PT school. I've worked with new grads. TJ and I teach in the United States. I've got 3 lectures that I'm going to be doing at a local physiotherapy school here in Frisco. And so I can just tell you, DPTs, they suck at manual therapy. You don't need to be intimidated. There, I think the background information is good. I think differential diagnosis is good, but the it's not as glamorous as it sounds. So after Doctorate of Physical Therapy, TJ and I went on and sat for a big bad exam with an incredibly low first time pass rate. I think the first time pass rate for the OCS and SCS are like less than 20%, which means 80% of people will fail the first time they take it. So me and TJ went on to become orthopedic certified specialists and sports specialists, which means a lot. If to be able to pass those exams, you're really demonstrating a high standard of knowledge and proficiency that most PTs don't have and won't ever have unless they're willing to put in the work and the effort. And then to become a fellow of the American Academy of Orthopedic and Manual Therapists, while I was specializing, I enrolled in this program, and it's another 4 years of education. It's a combination of education with tests and labs and practicals and working 400 and you have to accumulate 440 hours working under the world's like best physios. And they're scrutinizing every decision that you make, every technique that you do, and stuff like that. And so it's really a lot. And so to me, besides going PhD and stuff like that, this is the pinnacle of physical therapy education, of formal physical therapy education in the world. And so TJ and I can teach at the highest level and very authoritatively from our education and from our experience. And that's the level of information that we bring. And if you talk to any of our students, I know there's at least one of them that's listening in today, Suresh, but if you talk to any of our students, I think we have a good combination of making our material complex to the level that it needs to be complex, that you need to be able to understand things, but also accessible, understandable. And I think one of the things that we're good at GEM is teaching. Some people are not good at teaching, right? They can just talk and the teaching is not happening, but some people are really good at explaining things. And when we are teaching these techniques and stuff like that, I think that we do a good job with it. There you go. There's your track. So if you want to become an excellent expert manual therapist, you have your strong basic education, your BPT, your MPT, your DPT, whatever. Additional education, which could be the GEM program. It could be certification courses. It could be other formal things that you decide to go through. I think practicing with feedback from experts, which is something else that GEM offers. When you come to our courses, you're going to be practicing on other students. I'm going to make you practice on me. And when you practice on people that know what it should feel like, you can get much better feedback because your patients can't tell you that was a great cervical manipulation, or you need to do a little bit more of this, a little bit more of that. You know what I mean? And so that's one of the things that we offer. And then you continue to develop your skills with peers and other educational pursuits. Okay. Now for the meat and potatoes, or that's maybe not the best phrase to use for my veg guys that are tuning in today. We use in America meat and potatoes. It just means the substance. So maybe we should call it what's like a really heavy Indian food dish that you guys have, like sabzi, or what would be like a really filling meal that you have in India? I don't know. Paneer tikka, I don't know. So, but we're going to get into the substance now of our lecture. So let's talk about manual therapy for pain relief. I don't know how many of you guys knew this, how many of you guys didn't know this, but there are 5 different grades of mobilization, right? Grade 1 and grade 2 mobilizations, which are small and sometimes oscillatory, those mobilizations actually affect mechanoreceptors inside the body. they actually affect mechanoreceptors, type 1 and type 2, called Ruffini and Pacinian. And these mechanoreceptors, when you activate them, it actually reduces pain. So grade 1 and grade 2 mobilizations are great for pain relief. Is that a good place to start? Is that a good place to start if someone's having shoulder pain or neck pain or hip pain or ankle? You know what I mean? So, and then grade 5, a grade 5 manipulation has many, many effects, right? One of those effects is if there is a hypomobile joint that's not moving like it should, which is going to be stiff and painful, which is going to cause muscles around it to be tight and tense and hypertonic, and other muscles to become weak and inhibited. So one little joint dysfunction can cause a world of problems. And if you go in and you pop it, you have begun to set the whole system right again. Besides the biomechanical restriction that we deal with or free up the joint, there's also some neurological mechanisms by which there's pain relief and analgesia that happens. So grade 1, grade 2, grade 5, these are great for pain relief, right? Grade 3, grade 4, I think are generally used more to improve range of motion and hypomobile joints. You can still use them. Grade 4 mobilizations, which are mobilizations at the end range. Grade 4 mobs are actually really good before your manipulation because you're at the barrier, you're at the end range, you're doing some oscillations. So if you want your patient to relax, or if you want to get in a couple of quick little baby manipulations before you manipulate it, it's a good way to go. But grade 1 and grade 2, they actually affect pain receptors. Let's get those guys going. And then grade 5, good reasons to be doing grade 5. You guys should be able to do grade 5 and grade 1, grade 2 for every joint in the body so that when it comes into your clinic, you can begin that. And in conjunction with heat and stretches, you can help get the pain down really quick. Okay, I think we're going to start with thoracic spine. And I have got the whole body, thoracic spine, cervical spine, ribs, CT junction, hips, knees, ankles, feet, like everything. We've got everything in here. And we're just going to take a tour of the body. And I'm going to show you guys some of my favorite techniques. Recognize that each of these slides that we're going to do, we have a whole like 16-hour lecture with lab and demonstration and practice. So each of these slides represents a massive topic, right? But we're going to just cover some of the cooler part of that, which is just the techniques, right? Now, I have to say that I don't want you guys to be cheap manual therapists, right? I'm going to show these things, take these things, use these things, recognize that you still need to apply your clinical reasoning. You still need to determine if your patient is appropriate for manipulation or not. There's a list of probably about 10 or 15 contraindications for manipulation, reasons why you can't. And so I just begin this lab portion with the caveat, we're not covering that today because that would take a while, right? That's covered in our lectures with Jem and when to do it, when not to do it, how aggressive should you be in this phase and stuff like that to help you become a really excellent and effective therapist. But for intents and purposes today, we're going to show you guys some party tricks, but you have to use your judgment in applying them. Who are you applying them to, right? Like someone with osteoporosis or a fracture, like please don't, you know what I mean? Someone had a spine surgery. Yeah, don't try to pop that thing, right? Okay, all right. So thoracic spine, we're going to do some techniques. I want to say one more thing about it. The evidence for thoracic spine, in case you didn't know, almost every patient that you see is actually indicated, which means that they should have a thoracic spine manipulation. How can you say that, Dr. Ford? In neck pain patients benefit from thoracic manipulation, and I'm just going to spout from the research here. If your patient has neck pain, they should have a thoracic manip. If your patient has headaches and migraines, they should have a thoracic manip. If your patient has shoulder pain, they should have a thoracic manipulation. If your patient has neural symptoms, right? Not nerve symptoms in the upper extremity, they should have a thoracic spine manipulation. If they have nerve pain in the leg, they should have a thoracic spine manipulation. If your patient has pain around the low back and buttock area, guess what? Your lower thoracic spine could potentially be referring pain there, and you want to check it out and probably pop it. There's a million reasons to pop the thoracic spine. This is a good place to start. All right. So let's look at a couple manips here. I'm going to try to set up the computer so that you guys can have a good angle and stuff like that. What we're going to do today, that we haven't done before is I've got Aiden here. I'll let you guys say hi to him in just a second. And so what we're going to do is I'm going to do a technique on him, and then he's going to do the same technique on me. And we're going to play that game as we go, probably for the remaining 30 or 40 minutes of this lecture. So does that sound good? If everyone's good, just give me a little yes or a thumbs up or something in the chat box. Let me know you guys are ready. We're going to start in 1 minute. So if you need water, restroom, snack, do that really quickly while we get set up, okay? We'll start with some prone stuff. Come lay prone. I'll probably do like 2 or 3 techniques on you, and then you can turn around and do them on me. All right, guys. So the first technique I'm going to show is one that I like because it's one of the easiest ones to do. It's one of the easiest ones to do for the thoracic spine. Okay. So I've got my patient laying here, prone, comfortable. We can find the spinous processes, right? And I'm going to go quick. And if you want to get a better explanation, you'll have to tune into like a full-length lecture, okay? We're going to find our spinous processes. We're going to look for an apex of curve in the thoracic spine. We're going to look for the apex, which is usually around T7, T8. Aiden here, he has a little bit of our lordotic thoracic spine, which is not common, but you will see them. Do you guys see how flat it is here? Okay. From the spinous process, let's find the most curved part of the thoracic spine, which in Aiden is actually going to be lower down. And then I'm going to come about a centimeter to the side of each spinous process. I'm going to come about a centimeter to the side of the spinous.
So,
Yes.
sorry to interrupt you. Can you stop screen sharing so that the your display will be?
Yes, thank you. This is why. Yeah. Is
Yeah,
that better?
thank you so much. Yeah.
Okay, so yeah, you guys can click on my camera or my video feed and make it bigger so you guys can see. Patient's prone. We're going to use our hands, palpate the spinous processes. We know from the spinous process, if we come out about a centimeter, then we'll be on the transverse processes. And when we're manipulating thoracic spine in this position, that's what we want to be on. We can do The hand that's closest to me is going to be pointing towards his head. The hand that's further from me is going to be pointing away. There's a reason for that, is because this is thoracic spine manipulation position. If I change my hand and line my hand up along the rib and then move my hand onto the rib, I can pop the rib. So there's thoracic, there's rib. There's thoracic, there's rib, okay? So, but back to thoracic. So we'll be on the transverse processes of the same segment, right? Just pick one. And I'm gonna straighten up my elbows. You guys need to see this. We're gonna straighten up the elbows and get your chest over the segment that you're mobilizing. Okay, so there's a straight line between my mass of my chest, my straight arms, and my wrists. And I'm just going to lean my body weight. We can do some little mobs here, right? Can do some grade 1, grade 2. Do some grade 1, grade 2. And what I expect is that the thoracic spine should spring nicely. If it springs nicely, you don't need to manipulate it. So springing, springing, springing. Spring the thoracic spine. This is called joint mobility testing. You shouldn't just get on and pop it. You should get on and spend a little bit of time with it. Let's test the mobility of the joints. Sometimes while you're just springing, some of these joints will start popping. That's good. That's fine. Some people are very hypermobile and they'll pop easy. Once you've done some springing, if you felt there was a segment that was stiff or stuck or painful, then we want to get over that segment. This time I'm going to lean in my whole body weight, right? Have the patient take a deep breath in, deep breath out. And at the bottom of that, just breathe normally. And as soon as the patient lets out all their breath, I'm going to give a high velocity, low amplitude thrust. It's quite forceful. Like you're going to actually need to contract your abs, to drop your body weight, and all of your force is going to go right into that segment that you're on. You can't be a baby when it comes to manual therapy. You actually need to think mean thoughts. Okay, I know that sounds silly, but I'm dead serious. You need to think mean thoughts when you're doing manual therapy. If you go to do a manipulation and it doesn't pop, go again, a little bit harder. Go again, a little bit harder. You can do 2 or 3 thrusts until you get a manipulation, or even if you don't, at least you're getting your practice in. So manipulation for thoracic spine in prone, okay? So we did our oscillations, kind of testing the joint mobility along thoracic spine. And then we did a couple of thrusts. Okay, this is in the prone position. Let's talk about in the supine position, if you want to flip over on these back. So I'm going to do these and explain them kind of slowly with Aiden as my patient. And then after 1 or 2 or 3 techniques, then I'm going to come and let him demonstrate them without the explanation. You don't need to give it again. For a supine thoracic manipulation, you have the patient give themselves a hug, opposite arm on top. When I say opposite arm, that's the arm that's furthest from me. That arm's on top. The elbows are tight. Why is the patient giving themselves a hug? I can push through his elbows. Also, too, that's going to bring the shoulder blades out and away from the spine. So we can pop the thoracic spine or we can pop the ribs. What I'm going to do now is I'm going to take Aiden's spine, right? And then I'm going to make, for beginners and people practicing, a collapsible fist. So this is a fist, but it's collapsible. It's a soft fist. That's a hard fist. That's a soft fist, right? I can compress it. I can collapse it. I'm going to take a collapsible fist. And I'm going to palpate his spine. And wherever I feel like it's the most rounded or the most prominent, that's where it's going to be the stiffest. I'm going to take my collapsible fist and I'm going to put it right there. Doesn't have to be perfectly exactly anywhere. We just need a block, a physical mechanical block. That's going to come and sit at the apex or underneath the apex of the thoracic spine, so that when I give a force into his body, certainly the segment above where my fist is, that one's going to manipulate. Usually you get several different levels that will cavitate, that will pop, okay? So a collapsible fist. If you're advanced and you're really good at this game, you can use a flat hand. You can use a flat hand under the spinous processes, okay? And you can get enough fulcrum out of that. But if you're a beginner, you may need to use a collapsible fist, which would look something like that. Your fingers are there, but they're relaxed. Your thumb is there, but it's relaxed. Make sure your hand is relaxed when you do this, otherwise it'll be more uncomfortable for the patient. So I'm just going to grab this shoulder blade, roll it just enough that I can get my hand under his spine. So there's his spinous processes. I'm going to park my collapsible fist right under his spine, just like I showed you guys. I'm going to roll him over onto my hand. We're going to build pressure. So I'm going to compress my body down, 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 down. And then when I can't compress anymore, thrust. So here's what you got to do. When you first get on the patient, everything is loose. So you have to compress the patient's body down into your hand, compress their body down into your hand until you can't compress anymore. Then you can thrust through the barrier. Now, something that the nuance to this, the tricky part about that is I have to use his body to build pressure on my hand. So I have to roll him over to midline. And then I have to either push down this way or push this way or push that way. If I put my hand under his spine, and then watch this, I've got his elbows here, my chest is on top of his elbows. Watch how I can move my body. So depending on where my hand is, I need to get my chest and his elbows above my hand. So this is a sandwich. Your chest, the patient's elbows, and your hand. Those three things must be stacked to get that vertical force to go down into your hand. If my chest and his elbows are up here and my hand is down here, you're never going to get that manipulation. If my hand is up at the CT junction and my chest and his elbows are down at his belly button, like you're never going to get that manipulation. Does that make sense? So chest, elbows, and his spine and my hand. That's the sandwich, and that's got to be all aligned. If you put your hand under a patient's back and you get on here and you're just moving around, you can actually feel, oh, I can feel pressure there. Ooh, I can feel more pressure there, less pressure there. So based on where your body and that patient's elbows are, you have to be able to move around a little bit to hunt for maximum pressure on your hand, okay? That's thoracic. I'm going to have Aiden come and do a prone thoracic manip on me and a supine thoracic manip on me. If you want, you can do like, just pick a different zone for each one, you know? Sure. Yeah.
So go ahead and look towards your right hand side for me. Beautiful. Palpate through here. Take a deep breath in for me. Hold it out. Good.
Oh, nice. Beautiful. God, that feels good.
Excellent. Hug yourself like you love yourself. All right. All right.
Mhm.
Let's do this
Yes, nice. Like a pro. If you guys can be as good as Aiden, then it'll be great. Be amazing. All right, let's see what's next. You guys doing okay so far, by the way? The sound okay? The lighting okay? All right, I'm just going to reference the slide really quickly. One sideline, sitting and standing. Okay, all right. Yep, cool. All right, so just for kicks and giggles, we're going to go and demonstrate quite a few techniques, kind of a quick little montage here, just so you can see. Not going to be able to give all like the specific hand here, direction here, and stuff like that, but just so you guys can see some techniques. He may not need some of these or any of these, and so I'm not really concerned if there's a cavitation or a pop or not, but just so you guys get a chance to see these techniques. Will you strap the table facing that way?
Yes. Head this way.
Like riding an elephant, yes. Aiden's gonna ride an elephant. No, straddle like.
Oh, like
Wow.
this, yeah.
That's good. Okay, cool. I'm sure you guys have seen this one before. Give yourself a hug like that. This is you can use this for thoracic spine. You can use it for ribs, and you can also use it for lumbar spine. So what I'm going to do is I'm going to bring the patient in towards me. I'm going to rotate them away. By straddling the table now, his pelvis and lower back are locked out. So now all I do is need to turn the patient's body until I get my rib or my thoracic or my lumbar where I want it. So I'm going to come with the transverse processes. I'm going to use his body to take up the slack. We're going to rotate this way. We're going to side bend a little bit. You can play with flexion extension a little bit until I feel like I can get a barrier right where my hand is. So barrier there, 1, 2, and 3. And it's a push with the hand and it's a pull with the other hand. That's a rotational one. I have this technique I'm using a lot on a Parkinson's patient that I have right now, actually. She's a Parkinson's patient from India. I go to her house and do PT, and she loves it. She loves getting cracked and popped. And so every time I go, we do thoracic spine, we do some neck and mobs, we do some lumbar mobs and hip mobs and stuff like that. She loves it. So this is one version of a seated thoracic manip. You guys have seen the other one. Swing one leg over that way. Sorry. You guys have seen the other one, right? I used to do this one a lot when I was learning because I could do it successfully. And now I don't do it as much because it's really hard on the PT's body, especially if you're seeing 10, 15, 20, 30, 40 patients a day. Scooch back all the way, further. Okay. You're gonna give yourself a hug. You guys have seen the seated thoracic manip. If you guys are going to do this technique, you can do it without the use of anything. But if you want a particular segment to pop, what you can do is you can actually roll up a towel or a pillowcase, right? And let's say my patient's really rounded here, or they're really stiff here, right? Pick a spot. Remember how when my hand was under the spine, and I was like, okay, my hand is going to block the spine. So definitely the segment above my hand, that one's got a lot of room to move. That one's definitely going to pop. Same thing with this. If he's really stiff, tight, sore, whatever here, I'm going to place my pillow just under that segment, create a block, give yourself a hug, hold the bottom elbow. I'm going to wiggle my patient, lean him back, like he's sitting in a nice comfortable chair, lean back, lean back, lean back. And then I'm going to push my chest into the towel. So I've got him leaning back. He's a little bit extended. I'm going to push my chest forwards to engage that segment and create more tissue tension. And then from here, you just give a quick thrust upwards with your chest, with your hands. It's an upwards thrust. So you can use this for thoracic spine. If we change the position of the pillow case and have him put hands behind the neck, hands behind your neck, we can actually target a little bit more the CT junction, okay? So I'm going to find the most prominent part of CT junction. All right, it's usually around C7, T1, T1, T2. By the way, biomechanically, for neck rotation and neck movements, T1, T2, and T3. T1, T2, and T3. Those guys should actually all rotate. So when you rotate your neck, T1, T2, T3 should also rotate with the neck. So right now, I've got a cervical fusion patient. Everything is fused except for C1, C2, and C3. And so when he came in, his neck range of motion was horrible. And I was like, well, if you've got C1, C2, and C3, if you know your biomechanics, you should have at least 45 degrees of motion in your neck. That's how much you should have at C1, 2, C2, 3. 45 degrees of motion between those segments. So over the course of time, we've been able to get him closer to that 45 degrees. And one of the tricks that we've done is we've actually gone after T1, T2, and T3, because those guys, if they're moving well, should give you what? Better neck mobility. So here's how we're going to loosen up the CT junction. The definition of CT junction is what? C6 through T3 to transitional zone. Very important. All of the transitional zones are. And I know we're speeding through this, but I just can't do a weekend lecture in a short amount of time. So if you have any questions, let me know. But just so you know, there's this little present I'm giving you guys, is really unpacked better in our lectures, okay? But here's CT junction. Pillow on the CT junction or just below it, my chest contacting the pillowcase, my hands on his hands. A common error in this technique is that the therapist will be pushing on the patient's hands or pushing on the patient's head. Listen, the hands are just a contact, right? The hands are just a contact. And really, the therapist should do this. The therapist should be squeezing with their arms into the side of the patient body to hold them and then support them on your chest. So really, you shouldn't be pushing on the patient's hands or the patient's head. And please don't do, this is the absolute worst. You must never do this. Please don't do this one where you put your hands like this and then make the patient like stuff their head into their chest. Like, don't do that, okay? Patient should be relaxed. Their neck should be relaxed. I'm gonna wiggle my patient so they're relaxing. I'm gonna lean them back, press my chest into the pillowcase. Lean back and thrust. You have to be careful. Aiden is a big, broad, strong guy. And for me to be able to get around Aiden, it's almost too much that it's not a good technique selection. Because if you can't compress and hold your patient really well, then you are going to be either pushing on the neck, or maybe you'll be putting so much pressure on their glenohumeral joint. You don't want to cause an injury to the glenohumeral joint, to the labrum, whatever the case may be. And so it's nice to have a lot of different techniques that you can do, so that if a patient is small and light, pick them up and pop them. That's fine. If a patient's larger, you can do this. If they're bigger, stronger, whatever, you know what I mean? You need to have, and that's one of the things that GEM does is, I'm not going to just teach you how to manipulate thoracic spine. We're going to teach you how to manipulate it in like 10 different ways. The thoracic spine, the neck, the low back, the SI joint, the ribs, so that you can choose which works better for you. And you can also choose which works better for your patient. So that was seated thoracic, seated CT. We can also do a side lying. There's a side lying thoracic manipulation that's good for the lower thoracic spine. And it's actually just like our lumbar manipulation and side lying. So I'll show that to you guys. I'll do it on Aiden, and then Aiden can do it on me. Do you want to lay on your side? I'm going to do thoracic, and then I'll let Aiden do lumbar. So let me see if I can find a good view for this. You guys have seen this one before, but I like to pay attention to a couple of the nuances here. One of the differences between GEM, between the manual therapy that we teach and the manual therapy you can pick up on the street, is this. Manual therapy is either going to come from an osteopathic approach or from a chiropractic approach. Chiropractic approach, generally speaking, is more heavy-handed. There's more velocity, there's more amplitude, there's more force. They look violent. I don't know if you guys have ever watched on social media and seen a manipulation that you were just like, that was rough, that was violent, that was too much. The patient was not having a good time, right? So when we perform these techniques, there's a way that you can isolate your force and do these very gently, very softly, very gently. They're still quick, they're still high velocity, but the amplitude, how far you're pushing things, is small. High velocity, low amplitude, HVLA, high velocity, low amplitude. So I'm going to show you some of the nuances. And yes, it might be a little bit tougher to master up front, but your techniques will be better because they'll be gentle and they'll be specific. I can teach you how to manipulate one rib. I can teach you how to manipulate one joint in the neck, just the one that needs it. I can teach you how to manipulate the low back, just the one that needs it, to the point that I've had patients that have had a lumbar fusion or a cervical fusion, and the segment right above the fusion has had a nasty dysfunction, nasty facet dysfunction. And generally speaking, PTs, maybe even chiros, won't manipulate a spine that has a fusion in it. That's not a good idea. Maybe it's a contraindication. But after trying 3 sessions of everything else I could do, decompression, soft tissue, muscle energy techniques, the stuff that I would usually use to free that up wasn't working. And so we went in and we did a very gentle, specific manipulation for segment above the fusion, for segment above the fusion in the low back and in the neck. And we were able to successfully free that up without putting the patient in danger or at risk. And that's not the reason why you learn these things, but you should, as a manual therapist, an expert manual therapist, be able to isolate the segment that you want. What happens if, one more thing, what happens if Aiden comes in and he's got an L4 facet dysfunction, and I'm just a happy-go-lucky manual therapist, lay him on his side, pop his back, we hear a bunch of pops, right? And he gets up and his pain is still there. How do we know if we popped L4? By definition, a facet dysfunction is hypomobile, it's stuck. So if you have a facet dysfunction and you try to pop the whole spine, I promise you the segments that are not in dysfunction, they have better mobility. Like they're going to pop first because they're not locked up, they're not stuck. They may pop first. And so we can get a bunch of pops, and it's, in theory, everything could pop except for the facet dysfunction. So if you don't focus your force to the segment that you want, how do you know if you achieved your goal? Because if I pop everything and I think I popped it, but I didn't pop it, now I'm going to be trying other things to try to get that facet dysfunction better. And those things will be erroneous. And I'll be banging my head against the wall. Why does this hurt? Why can't he do this? Why doesn't that move freely? You know what I mean? And so the specificity we're going to go to for lumbar manip and for cervical manip is very, very, very high. And that is the standard that we at GEM set. You need to be able to manipulate a specific segment. I think the research gives leeway for within a segment or two. So if this is our zone, you need to be able to manipulate within this zone. But me and TJ will tell you, you can manipulate a particular segment every time if you know what you're doing. So patient is side lying. We're going to say that we're going to go after L4, L5. Put on your thinking hats, all right? So if we want to go after L4, L5, here's how I'm going to target that. I'm going to lock out Aiden's entire spine except for L4, L5. So nothing in his spine can move except that segment. So when I give a thrust through his pelvis, guess what's going to pop? L4, L5. Here's how we do that from the top down and then from the bottom up. So the first goal is to lock out thoracic spine and lumbar spine. So I'm going to take his bottom hand, put it under my armpit, under my shoulder blade. I'm going to grab his arm and I'm going to pull him. We could do different pulls here depending on the type of manipulation. I'm just going to pull him into flexion and rotation. All right. So I'm going to pull him forward and my hand is watching L4-5, right? I'm actually on L4. So I'm going to pull his thoracic spine and lumbar spine. And as soon as I feel movement at L4, the spine is locked out to L4. We're done, right? He can hold onto his hands. So everything's locked down to L4. That's perfect. Now I want to make sure that L5, S1, that segment is locked up. And I'll do that by adjusting this top leg. So I can lock out L5, S1 by flexing and extending this leg. So I'm actually going to flex this top knee until L5 starts to move. So there's tissue tension all the way at the top, all the way at the bottom. L4, L5 is still mobile. I'm going to roll him towards me so that I can get on top of his pelvis. I actually want to get my chest on my forearm on the outside of his pelvis. Okay. So roll forward, get on top of the pelvis, make some last minute adjustments with my hands. Make sure thoracic's good. Make sure lumbar is good. Okay. 1, 2, 3, and thrust. Okay. Why don't you come do a lumbar on me as well? Sure.
Excellent. Scooch a little bit closer to me if you don't mind. Make yourself like you love yourself.
Nice. Nice one.
Thank
That
you,
was
sir.
awesome. Appreciate it. I see a lot of different like lumbar manips. And the nice thing about when we do it the way that we do it, you're using tissue tension to lock out the spine. So I don't have to like dig my thumb into one segment to keep it from moving while I'm trying to pop another segment. Makes it like really easy on your hands, on your body. One of the things that we didn't show, goes without saying, but I like to point it out, is that besides understanding how to do it, you also need to understand like PT body mechanics and even the height of the table. So I don't know if you guys noticed or not, but under my table, I've got this little step. Sometimes I'll need to get up on that for better biomechanical advantage, right? To be able to get my chest above the patient for manip or whatever. We also use high-low tables, which are really nice, but not everyone has those. And then the other thing is when we're doing manips, you're going to see our body positions, especially when we do the live lectures or the longer lectures or the in-person lectures. But you're going to see our body positions we're using our bodies in such a way that you get force and power from your body. If I just climb on top of a patient and I'm trying to manipulate them, I see this all the time, right? I'm trying to manipulate them. There's no force here. There's no power here. But if I can get a strong stance and use my body, right? It's called a foot drop. My back foot is in the air. I'm on top of the patient's pelvis and I'm going to drop my whole body isometrically. It's the same for the lumbar manip. This is the same for thoracic manip. It's the same for even a CT manip, which I guess we can come and do next, right? A CT junction manip. Let's do a CT junction manip. And I believe this is going to be recorded. That way, if you guys want to look back over these, I don't know, the explanations are not fully complete because we're trying to cover a couple of different things. But yeah, like I said. Okay. So we've got C7, T1, T2, T3. We talked about how important it is that those guys are moving, right? So this is another technique for CT junction. We saw the sitting one. We can pop it supine, just like we did the thoracic spine. We can pop CT junction. All I have to do is get my hand higher up here and adjust my force so that it goes through that. Okay. Can also do CT junction and prone. So in order to do that, what am I going to want to do? I'm going to want to move one segment on another, which means I'm going to need to block a segment. So I'm going to come just to the side of, let's do like maybe T1 or T2. So I'm going to come and block to the side of T1, T2, let's make it T2. There's the spinous process. 1 centimeter to the side of that is going to be the transverse process. So I'm going to put my pisiform on the transverse process on this side. I'm going to gently, with his chin on the front of the mat, this is called chin pivot thrust. His chin is on the front of the mat, chin pivot thrust. Chin on the front, pivot the head to the side, okay? And I'm going to just very gently, I'm not putting a lot of weight or force or pressure through this hand. It's just to get it there and hold it there. Chin, pivot, and then I'm going to lean my body weight. And I really want to zoom out for the body on this one. I'm going to lean my body weight into this hand. So hold the head, lean my body weight into the hand. Right now, there's no pressure on his body. Now I'm compressing his shirt to his skin. I'm compressing his skin to his muscles. I'm compressing his everything down to the transverse process. Okay, that's the point at which now we're basically at the barrier. I'm going to push a little bit more, going to oscillate a couple of oscillations. And then I'm going to do this with my body. I'm going to just drop it. 1, 2, and 3. Okay, so your body mechanics are really important. There's actually drills. I'll give you you can hop up first. There's actually drills that I give to my students to practice these manipulations. I want you to, you're actually going to thrust into the table and you're going to move the table doing like isometric body pushes. Okay. And you need at least that amount of force to like make this manipulation happen. Okay. I'm gonna let Aiden come and do, you can go ahead and knock out both sides if you want. Sure. The only thing you may want to check is just that you can see yourself good. I think this is a pretty good. I think this is a pretty good angle, but you can see what you think. You can bring it close if you want.
I think that's good.
Whatever you think.
Yeah. It's actually, you had it really good.
Nice.
Beautiful. Wow.
Nice. Rock star.
Nice. Thank you. Thank you.
What I didn't tell you guys about this manip that's so cool is that if you change the thrusting hand, you can actually manipulate OA joint. And it also too, you can go after the ribs. So with the patient in the same position, if I take my hand off of the transverse process and I put it onto second rib, you can pop second rib. On third rib, you can pop third rib. Lay on your tummy. I'm not going to do it, but I'm just going to show like the hand position, the difference in hand position real quick. And then I'm going to show my 2 favorite techniques for the neck, and then we're going to probably close it up for the day. So if I just take my hand, right, this is the map. The body's a map. Where are some of our landmarks? Here's the C7. It's the most prominent spinous process at the base of the neck. T1, T2, T3. Okay, cool. I can also come here and find the ribs. So first rib is like a choker necklace. It's right at the base of the neck. So there's first rib. Second rib is right in here, just above the shoulder blade. There's second rib. There's third rib. There's fourth rib. So any of these ribs in here, I can actually come off of the transverse process with my hand and angle it where that rib is, right? And the arm is off the mat, so the shoulder blade's out of the way a little bit, right? And angle my hand where that rib would be. I can spring on the rib. I can bring the head over here, makes things a little tighter. So I can spring on these ribs And I can actually determine, ooh, that one moves good, that one moves good, that one moves good. If you find one that's like stiff or prominent or painful, then you can go ahead and repeat the procedure. Hold the head, lean my body weight to get my body behind my hand, have patient breathe in, breathe out, and thrust, okay? Ribs in supine is by far my favorite, and I think it's more effective and easier for the PT, but you can knock ribs out in prone, especially some of these upper ribs. They're a little bit easier to hit in a prone position, okay? Let's go ahead and show you guys my two favorite techniques, and probably of all the things we've learned today, I think these are the most two accessible, the easiest to start using like right away. And for every neck patient, every damn neck patient, probably 99.9% of your neck patients, this technique will feel good. And you will, if you're like me, you'll adopt this into your regular neck treatment routine. On day one, I would say all of my neck patients get these two techniques on the first day, sometimes the first couple of sessions. The first one you guys have probably seen or heard of because it's popular. It's called the suboccipital release. So we're going to come to the occiput, right, which is the skull. And then right where the skull meets the neck, there's all those little muscles, the suboccipital muscles. And I think in an upcoming lecture, we're going to emphasize more neck, and we're going to do dry needling for the whole body, including the back of the neck. And we're going to show some really cool stuff. But for now, just so for basic orientation, find the occiput, come to the base of the occiput. You go from skin and bone to now there's a little bit of muscle in there. And the occiput has this sharp kind of drop off that makes for a nice place where you can get your fingers and hold. First thing, we're going to do a lumbrical grip with the hands. So what that means is you're going to use the muscles in the palms of your hand to bring your fingers like this. Do you see how my fingertips, are they straight or are they curved? Are they straight or are they curved? They're straight. If you curve your fingers, you're going to take that little bony distal phalanx and you're going to stick that into muscles and nerves. The patient doesn't want that and you don't want that. We want to use the pads of your fingers. It's going to create a nice lumbrical grip. Okay, so this is how we're going to hold the head. So come to the base of the skull. Here's where the muscles are. I'm going to find a place where I can park the pads of my fingers. And I'm just going to engage that lumbrical grip a little bit. I want to make sure my patient is relaxed. So I'm going to give his head a little wiggle. And with those lumbricals engaged, I can just lean my body back. And as I lean back, I'm going to feel, I'm going to be able to pull his neck a little bit. It's going to give a little bit. And I'm just going to hold it there. I usually say you want to hold for at least 20 seconds, but definitely until the patient relaxes. When the patient relaxes, they're going to change their breathing pattern. You'll start to see like a deeper breathing, slower breathing. They're relaxed. We're going to hang out here. This is a form of traction, basically. One of the things we know about traction or decompression is that it's better done in intervals. So instead of me trying to hold this for 10 or 15 minutes, I'm going to hold it for about 20 seconds. I'm going to slowly let go. I'm going to take him back up. We're going to hold for another 20 seconds. And I usually do that about 5 or 10 times. This is a great pain relief relaxation technique. After doing this for 2 or 3 sessions, remember how we talked about there's some muscles on the front of the neck that are weak, the deep neck flexors? We could engage those. And at the same time, so many people have this forward head posture, and so we can engage some cervical retractions. And so I love this. Watch this. Same technique. I've pulled him back a little bit. And then once I've engaged the pull, I'm going to tell him, all right, I want you to tuck your chin a little bit. And as they tuck their chin, that's going to engage the deep neck flexors, which need to be activated, which needs to be turned on. And then while you keep your chin tucked, I want you to also gently press back into my fingers. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we're getting pain relief, deep neck flexor activation, and cervical retractions all at the same time. Let me tell you, that is very clinically efficient. We are killing like 3 birds with 1 stone, right? And this is your first technique on your patient. Are they off to a good start? Oh yeah. Let's do that one more time. So I'm going to pull your head. I'm going to have you tuck your chin. I'm going to have you press back gently. And it's very gentle. It's like maybe 20% of their force. You just want to feel them activate those muscles, and that's it. If the patient's pushing too hard, you got to tell them, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. Okay. I'm going to grab a pillow for the next technique. So that was called suboccipital release. And you can also do it with some cervical retractions. 99.9% of your patients need this, would benefit from it, and they're going to love it. So do it. That 0.1%, and it really is probably about 0.1%, but once in a blue moon, you get a patient where their greater occipital nerve is unhappy. And if the scalene, if the suboccipitals are like this, right, greater occipital nerve travels through your suboccipitals. So once in a while, someone's greater occipital nerve is inflamed, irritated, hypersensitive. And when you push on that part of their neck, they might feel pain up the back of their head to the front of their forehead. They might feel pain in like a ram's horn pattern, or they might even feel pain kind of in the eye socket. All right. So if they don't tolerate your fingers being there, that's fine. Let's get a different technique. If greater occipital nerve is not happy, you could try decompression. They probably need an occipital-atlantal manipulation or muscle energy technique. But that's just on the side. You can almost just log it away and forget about it because it's very rare. Suboccipital release with cervical retractions. And I usually don't do the cervical retractions until we've had 2 or 3 sessions and patients are feeling better, but that's up to you guys. Okay. All right. So here's the next technique that I love. All right. Let me show you guys this. In the neck, if you get pain, headaches, migraines, any kind of pain in the neck, in the traps, anything like that. Okay. Usually you're going to find facet dysfunctions, which means that one or more of the joints in the neck are going to be locked and unhappy. All right. When that happens, the scalene muscles, we've got anterior scalene, middle scalene, posterior scalene. Anterior and middle scalene attach onto which ribs? First rib and second rib. So we've got a neck problem. Secondary thing that happens is my scalenes become hypertonic and they have attachments. So what's the tertiary thing that's going to happen? First rib or second rib can get pulled up. Okay. So that rib is now sitting in dysfunction. It'll probably be stiff and painful, especially if you palpate it. It's going to be stiff and painful. The other problem with the scalenes is, do you remember the scalene triangle, scalenes and first rib? What travels through scalenes and first rib? Your neurovascular bundle, right? Brachial plexus, brachial artery. And so when we get a small problem in the neck can make scalenes hypertonic, elevate the first rib, and now it can create any kind of neural tension in the arm is fair game. Any kind of numbness, tingling, heaviness, cramping, shooting, whatever is fair game. And so you have to start at the neck, right? Let's make the neck feel better. We can do some manips, some decompression, some suboccipital release. After that, we need to get these scalenes better. What are you going to do for the scalenes in the first rib? You're going to get in there and like mash on first rib and do some first rib mobs? You can, but that doesn't make sense. Address the primary problem, which is the neck pain or the facet dysfunction. That means you might have to pop 1 or 2 things, right? So that the scalenes can be happy. After we've addressed the problem, whether it's a manipulation or muscle energy technique, whatever, right? So now what we're going to do is I'm going to find that first rib. I'm going to compare and be like, oh yeah, like on your painful side, this first rib is elevated. It's sitting higher. And the patient will probably tell you like it's tender too. So I'm going to take my fist and I'm going to put it onto first rib. So here's first rib. I'm going to put it onto first rib. So my first knuckle is hitting first rib, and the rest of my hand is just compressing soft tissue to distribute the force and pressure equally so it's not too pokey. If I just went in like that with like a karate chop hand, like that's going to hurt. So you need as big a surface area as possible, right? So I'm going to pin down the first rib. I'm going to keep that first rib down. Now, if I have Iden rotate his head away from that side, as he rotates, these scalenes are going to begin to pull. They're going to begin to elongate. And since I'm pinning down first rib, we're going to stretch the scalenes. So as he turns to the right, he is doing like a self-stretch for the scalenes. The other thing that's happening is a muscle energy technique. You guys have heard of reciprocal inhibition. If he turns on the muscles on this side of his neck, on the right side of his neck, the way the body works neurologically is that the brain shuts down the muscles on the opposite side of the neck to allow movement. That's inherent in the body. If it wasn't, you would never be able to move anything. So pin down the rib, turn to the right, and if the patient does that actively, we can gently go to the point of feeling a stretch. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. Let's do that a couple of times, just as effortlessly as possible. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax and go again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And what you'll see with your patients every time is that the first turn is going to be limited. 2, 3, 4, 5, 6, 7, 8, 9, 10. And then the next turn, they can go a little bit further. And by the time you've done 5 or 10 turns, they're going to go from maybe 15 or 20 degrees to the full 80 to 90 degrees. In the last couple of turns, I'll tell the patient, try to go a little bit further each time. Try to go a little bit further each time, gently. And sometimes I'll use my hand on their head to guide them. They should go until the first point of tissue tension. Don't let them go too hard. Don't let them go too soft. On a scale of 10, maybe like a 2. Like you actually want to feel where you're holding that rib and the patient's turning their neck. You're going to feel the scalenes get tight and begin to pull on your hand. At that moment, we're going to stay there. Just a gentle stretch, a gentle pressure for like 10 seconds. Do you guys have any questions about that or any of the other techniques that we've done for today? Next time we tune in, we're going to cover cervical manipulation, a variety of different cervical manipulations, rib manipulations, shoulder manual therapy, right? Manual therapy for the neck, the ribs, the shoulder, the elbow, the wrist, the SI joint, the low back some more, the hips, the knees, the ankles, everything. And I think we might even, if we have time, we might even show like a little bit of dry needling techniques, but if not, that's okay. Ronak, where can I read all these? Okay, Ronak, so here's what we're going to do. I think we're recording this lecture and you can access it. Keep in mind, okay, so just keep in mind, the point of this lecture is to see into a bigger world. All right. And through GEM, we do have an online certification program where you can go through our courses. They're about 16 hours each. So we go through this at a slower pace with all of the information you need, with the slides, with the lectures recorded. And so you have everything at your fingertips that you can do it self-paced. You can also come to our live courses, our hands-on courses. So Ronak, I don't know where you live, but we're going to be in Mumbai from December 2nd through December 8th. Dhrumi can get you the information. Where's the reference book? The reference book is millions of books and lectures and resources. This is GEM material. So we've taken information from all over the world, America, Australia, Canada, research from all over the world, the best and brightest minds in the physical therapy world, and it has been combined into one resource. That is GEM. That is us. And so this is a short lecture that's just meant to show you into a bigger world, either to whet your appetite so that you can do some great continuing education where you live, or if you guys want to sign up for our online program or for our hands-on that we're going to be doing in Mumbai, then you can. So that's what we have right now. We do occasionally offer courses in the US. We are looking to offer courses in different parts of the world. Hopefully like Dubai or Qatar. Would love to offer one in like Nigeria or Africa somewhere. Aiden has friends and families in different parts of, what would you say, like Turkey and Iran. And so, you know, we're definitely open to teaching anywhere hands-on courses, but our recorded courses are amazing because they cover all the lecture, all the lab slides and stuff like that. So if you want more information, Dr. Drumi, who is the young lady that you guys have been in touch with, she's really amazing. She's been with us for a long time. She was a star student, and so we brought her on board with us. She's a physiotherapist in Thane and Mumbai, and she's really amazing. A great PT, a smart young lady, and has a really bright future. But if you guys have any other questions, if you want to get with her, you can. We are going to be doing these lectures every Sunday through the end of the year at about the same time. So make sure you tune in to some more of these, and would love to have active discussions and stuff like that. But yeah, feel free, if you guys are done, you guys can tune out for the day. Feel free to reach out to Drumi if you have any questions. Like I said, we'll be doing a lot of these free lectures. We've got so many exciting topics that we're going to cover. You wouldn't even believe. To improve differential diagnosis quality, I think that's substance that would come from courses like the ones that we teach. I don't know anyone that does a better job. I'm just going to tell you, frankly, but I also honestly believe this, is that no one else teaches at the level that we teach. You know, this is a really short lecture. It's hard to decide how much to throw in, how much not to throw in. But the quantity and the quality in our recorded lectures, which you can get from Drumi, covers everything you need it to. If you guys have ever tuned in to one of TJ's lectures, he's the smartest. He's not only the smartest and best physiotherapist that I know, I think he's one of the smartest people that I've ever met. And so when you talk about differential diagnosis, we're able to help you see it clearly. He's super smart. I think I'm really good at making things accessible and understandable. And so we make a really good team for that reason. Differential diagnosis, honestly, it's not that hard, but you do need a good resource. If you want to try ours, maybe you can get one of our courses and see what you think. But we have courses that cover the whole body and several electives that cover additional things as well. But yeah, we are going to do, you know what, Najibur Rahman, several of these courses we're going to be doing over the next couple of weeks are going to cover differential diagnosis for some really common things like foot pain. Is it plantar fasciitis, or is it the back, or is it the nerve, or is it the tendon? For a tennis elbow, is it the nerve? Is it the radiohumeral joint? Is it the tendon? Pain by the shoulder blade. Is it the neck? Is it a muscle? Is it a rib dysfunction? Is it a facet dysfunction? So we're going to cover stuff like that, but definitely feel free to talk to Drumi. She can answer some questions. I hope any of you that can will start thinking about joining us in Mumbai, December 2nd through the 8th. It's going to be amazing. We're going to cover manual therapy for the whole body, and we're going to be doing a really great hands-on Najibur Rahman. Great. Excellent. I look forward to discussing more and definitely seeing some of you guys in Mumbai later this year. And you will see Aiden and I around for the next couple of weeks. So he's a good example of what a little hard work and dedication can get you. All right. I'm going to field questions for maybe another 3 or 4 minutes, and then I'm going to tune out. So if anyone else has questions, make them known. And thank you guys. Thank you guys for tuning in and listening in. I hope it was interesting and informative. Hopefully you guys learned a thing or two. I don't know if Ukasha is on or not, but he asked a question about referring to regional interdependence. Absolutely. Absolutely. So regional interdependence, which is something that everybody should know about and understand, is that when you're treating a body part, you have to treat the system, the neurological system, the joints, the muscles, the tissues that all contribute. And so when you're dealing with necks, you need to treat shoulders, shoulder girdle, thoracic spine, and ribs, at least, right? When you're treating shoulders, you have to treat neck, thoracic spine, ribs, shoulder blade. When you're treating low backs and hips, you got to treat lumbar, thoracic, SI, sometimes the pelvic girdle. You know what I mean? And so regional interdependence is just this idea that you have to be able to treat the system. And that's one of the things that GEM is better at, I think, than just about anybody else, is diagnosing correctly, deciding what in the system needs to be addressed, right? And you can do that in like 5 minutes when you know how. And then being able to provide the interventions necessary, whether it's manipulation or muscle energy technique or soft tissue technique. You just need to have a lot in your toolbox, but what you don't need in your toolbox is bullshit, if you'll excuse the French. And there's a lot of bullshit out there. There's a lot of rubbish out there in terms of what people say. Oh yeah, do this, do this. Okay, that's fine. But please, guys, that's why we have research. That's why we have evidence. And you're only going to hear evidence-based interventions from us in terms of what is the best use of your time, what is the best use of the patient's time. And the cool thing is that the type of therapy we do, it does not require a fancy clinic. It doesn't require fancy equipment. You need your brain and you need your hands and maybe a treatment table. I do all of this as a freelance PT as well. I take my table to people's houses, use my hands, popping, cracking, then we do some stretches, then we do some exercises. Sometimes we do some needling. I can take my needles with me, right? It's really easy, guys. It's really easy, guys. Time and effort. That's all it takes. All right, well, I think that's it for the questions. So thank you guys for tuning in. I'll see you guys next Sunday, same time, same place. We'll be covering part 2 for this lecture. Thank you. Bye. Thank you, Dhruvi.
Thank you so much, sir.
Yep. I'll see you later.